this is as opposed to bladder cancer where we see these really, really dramatic responses, immunotherapy in prostate cancer I think is a lot more subtle. And as we identify those patients who benefit from immunotherapy in this disease, I think we'll really see a lot more survival benefit. And I'm going to talk about some of the different things right now that are showing this. See, we know that malignant growth results from not only neoplastic transformation, but also to resistance to the immune system and the ability for the cancer to evade host defenses. Immunotherapy is basically being used to overcome this tumor-specific issue that they can avoid the immune system, and we want to look for different antigens and targets and effective presentation so that the patients potentially can benefit. We know that prostate cancers are inherently immunogenic. There are a variety of different prostate-specific markers that can be targeted, particularly prostatic acid phosphatase as well as PSA. And we can begin to engineer immunological interventions that can protect the tumor from, or at least the patients from these particular tumors. So there are a variety of different ways of trying to attack the immune system. One is to go and to sensitize the immune system to different antigens. The other is to basically take the brakes off the immune system, and that's where checkpoint inhibition therapy comes into play. So we do actually have 2 FDA-approved agents for prostate cancer. I'll talk about the second a little bit later. It's not specific for prostate cancer. But Sipuleucel-T is a prostate-specific process that is approved by the FDA. What this process does is it takes the patient's own immune cells, the lymphocytes. These are removed through a leukapheresis. These are then exposed to a combination of prostatic acid phosphatase plus GM-CSF. The antigen-presenting cells will pick up this particular complex. The antigen is processed. You have a fully activated antigen-presenting cell that is then reinfused back into the patient, and then T cells recognize these particular antigens. They become sensitive towards the prostate cancer cells, and they attack them. This process is repeated with Provenge or Sipuleucel-T a total of 3 times, where you have 3 phereses and then 3 reinfusions of these particular immune cells. This has been a controversial product. The reason is there's a disconnect between progression-free survival and overall survival. You generally do not see PSA declines. You don't see objective responses in soft tissue. You don't see regression of bone lesions. But you do see a survival benefit, and that is evidenced by a hazard ratio of 0.775 and a median difference of about 4.1 months. So this led investigators and clinicians to be really, really skeptical of this data when it first came out. Why would you see the survival benefit and yet at the same time not see differences in PSA declines or differences in progression-free survival? And also, I think it's important to note that the patients that were on this particular study were asymptomatic. They did not have visceral disease. In other words, they didn't have liver mets. And they also, interestingly, could have had prior chemotherapy. About 15% of patients did have prior chemotherapy on this study. So how do we explain this? Well, one is an issue of volume of disease. If we look at the median PSA at which patients receive Sipuleucel-T therapy, we see that as you go lower, or you go higher, whichever way you look at it, the lower the PSA, the better chance you have of getting a survival benefit. So the median difference at PSAs of less than 22 is about 13 months, and that's significant. It's significant for 22 to 50, but it's non-significant for these higher PSA values. And that may be a reflection of the number of patients that were looked at in this particular analysis. Hazard ratio 0.5, 0.74, and it also begins to worsen as you go higher. So perhaps this should be given early and also to patients who have low volume of disease, and maybe that's the reason why we're seeing this disconnect. We've actually also looked at some of the other vaccine data. This was done by Dr. Madden at the NCI, where what you do is when you look at or compare cytotoxic chemotherapy to those patients who are undergoing immune therapy and look at the slopes after treatment, you'll see that with cytotoxic therapy, you'll see a decline in the PSA, and then once they progress, they return to a similar or steeper slope in growth. In patients who are treated with immune therapy, it's blunted. It's a bent arrow. So perhaps what immune therapy is doing is slowing the disease down, or at least this type of immune therapy. The question also has, when we see all these other agents, can you give these agents safely together? Do some of our agents, such as enzalutamide or abiraterone, affect T cell function? And also, do they affect Sipuleucel-T activity? So this is a randomized trial that I did with David Quinn, phase 2, looking at Sipuleucel-T for 3 doses, and then giving enzalutamide at the same time concomitantly, or Sipuleucel-3 followed by enzalutamide. There was a very, very similar study that was also done with abiraterone and prednisone, very similar in the same sequences. And we found that there was no difference in immune function, but we also found that same PSA quartile issue that we saw before, that the lower PSA values, this is a much lower spread, the lower PSA values were correlated with overall lower volumes of disease and better outcome in our patients. We also see that the durations of exposure to enzalutamide, adjusting for the time off of Sipuleucel-T, are very, very similar. And this, again, is the quartile data. We see that the best hazard ratios occur in the patients with lower PSA volumes. So there's no effect on immune function, and you can give these either sequentially or giving them concomitantly. But again, this issue about PSA and Sipuleucel-T and the volume is important. The other thing that people neglect is the fact that even though these are asymptomatic patients, they can progress onto pain. This is analysis that I published a couple of years ago looking at the 3 Sipuleucel-T randomized trials and looking at intervals without pain. And if you receive Sipuleucel-T, there's a 12-month pain-free difference, 39% in favor of Sipuleucel-T versus 19% in the control arm. And this was statistically significant if you take into account the administration of narcotic analgesics. So again, we see the same pattern. There are other types of antigen-presenting situations that have been evaluated in large trials. This is Prosvac. Prosvac is a vaccine that's basically using PSA as the antigen gene, and then 3 co-stimulatory molecules. That's where TRICOM comes from, LF3A, ICAM, and B7-1. This vaccine is given intradermally and then induces T cell responses, almost in a similar way to what you would see with a dendritic cell. The initial studies that were published by Phil Kantoff demonstrated a trend towards an improved survival in favor of those patients who received Prosvac versus those patients who received a placebo vaccine. So there was a suggestion that there was a survival benefit. Again, no difference in PFS with this particular treatment. So this led to a large randomized trial of Prosvac plus GM-CSF versus Prosvac alone versus an empty vector placebo. Patients received priming and then 6 boosts, and they were followed for survival. Unfortunately, when this trial matured, it was presented last year at ASCO, there was no difference in survival for those patients who received Prosvac versus the control group. So at least in this particular situation, the vaccine approach did not work. So it failed to confirm the initial observation, and there was an overall survival that was 1 year longer than anticipated for this particular trial. So that actually shows you from all these downstream elements how difficult it is to design trials in this era. What about checkpoint inhibition therapy? These are ways that the immune system can be unmasked. It's almost like Star Trek, where you have the cloaking device that the Klingons can use to hide themselves from the Federation ships. Once you take the cloaking device away, they're visible to the Federation, they can be killed. So the cancer cells do the same thing. They have many mutations, and mutations are important here to our understanding of immune therapy in this disease. The T cells can recognize these mutations and then can determine that these cells are foreign, and they can attack, and the cancer cells evade this by expressing something called PDL-1. This will shut the immune system off, and this is done through the mechanism of the PD-1 axis, and this prevents the T cell from recognizing the cancer cell and then activating different cytokines to kill it. There is also another pathway too, which is called CTLA-4, which the drug ipilimumab will inhibit, and that's a drug that is approved for melanoma as well as for some other solid tumors as well. So 2 different ways of basically shutting the immune system off and preventing the immune system from recognizing prostate cancer cells. This reactivates the immune system by inhibiting this and then causes cell death. So what about clinical trials in prostate cancer? Well, they are all over the place. And it's a little bit difficult, but we'll try to get through this data and figure out exactly what some of the pathways are. So this is the ipilimumab trial that took patients who were post-docetaxel for castrate-resistant prostate cancer. They were given 1 single dose of radiation therapy, something called the abscopal effect. And what that is that you're radiating one spot to release antigens, and sometimes you will see tumor regressions in other areas. Patients were then randomized to receive ipilimumab, initially for 4 doses, and then a maintenance dose every 12 weeks, or a placebo, and then a placebo maintenance. Primary objective was overall survival. No difference in overall survival, about 11 months for ipilimumab versus 10 months for the placebo. But a very, very interesting pattern was noted. And that was that the patients who benefited were those patients with bone-only disease. The patients with the visceral metastases actually did worse in this particular study. So had this trial been designed in bone-only patients with survival being the primary endpoint, it would have been a positive trial. So patient selection is becoming extremely important for us to properly administer immunotherapy. Now, getting back to the PD-1, PDL-1 axis, the data is all over the place in prostate cancer. Firstly, if we look at hormone-sensitive radical prostatectomy specimens, and this trial is somewhat controversial because of the methods that were used to assess PD-L1, but about half of those particular specimens will be found to have PD-L1 expression on the prostate cancer surface. So perhaps hormonal status has something to do with it. Well, in fact, if you look at dendritic cells in patients who have been exposed to enzalutamide, you'll find that there's an upregulation of PD-L1. And so perhaps giving these drugs after hormone therapy is the right time to give it. We really don't know at this point. In a very small cohort of patients from the original nivolumab trial, this is a PD-1 inhibitor, 17 patients were treated. 2 had tissue that stained for PD-L1, which were negative. And this was before the abiraterone enzalutamide era. No responses were seen. Another trial showed that about 15% of castrate-resistant specimens will express PD-L1. So it's a really, really heterogeneous group of patients. So how can we start to try to unify this particular fact? We go back to DNA mutations. And William's going to be talking more about this afterwards. But we know that there are certain conditions, one called microsatellite instability, that will be seen in patients, and this is basically a state of genetic hypermutatability. So these patients will not be able to repair their DNA. The MMR will actually correct these errors in the DNA and will actually repair single base mismatches or short insertions. And this will lead to microsatellites, if it can't be corrected, that are of small sequences of DNA. Actually, it's almost like a DNA fingerprint for a patient. And these small sequences accumulate and actually can cause different neoantigens. So this is something called microsatellite instability. Often these are GTCA repeats that are seen within these small different fragments of DNA, and this is seen in prostate cancer. So this was a trial that was published this week in JAMA Oncology, looking at 1,033 patients from Sloan Kettering. And what they found was that 3.1% of patients had microsatellite instability. 2.2% of these patients had indeterminate levels, and additional 9, had high levels, and then 9 had indeterminate levels. And 7 of these patients had a germline mutation with a Lynch syndrome-associated gene. There were 6 patients who had more than one tumor analyzed. 2 of them were found to have upregulation or development of MSH later in their disease course. So it's interesting, this may be something that also develops as mutations accumulate in a prostate cancer specimen. So there were 11 patients who were on this particular, as I mentioned before, 11 patients treated with checkpoint inhibition therapy with anti-PD-1 or anti-PDL-1, and about 55% of these patients responded, partial responses. and some, of course, progress, but we do see responses 55% by PSA and about 30% by soft tissue disease. So what does this mean? Pembrolizumab is an FDA-approved drug. It's the first drug that was approved on a pan-tumor basis. So what do I mean by that? Well, it's approved for every cancer that has microsatellite instability. And as we saw before, 3% of patients with prostate cancer have that. So in the original trial, there was one prostate cancer patient that showed an objective response. It may be higher, but these numbers are small. But every patient who has castrate-resistant disease needs to have this particular marker evaluated, because the differences or the results can be fairly dramatic because of the fact that we have pembrolizumab that can be administered to these patients. So all of our patients at Yale are checked for microsatellite instability when they are castrate-resistant. There are other markers as well, again involved in DNA repair, that may have an effect on neoantigens and immune response. So CDK12 is another class of mutations seen in prostate cancer. These will also lead to genomic instability, gene fusions, and neoantigens, so more antigens on the prostate cancer cell. This makes them more recognizable to the immune system and potentially sensitive to checkpoint inhibition therapy. And again, we see responses. This was a paper from Arushanayan's group that demonstrated responses in patients who had CDK12 mutations. And these are basically deletions of the kinase region of CDK12. But you see here again, PSA declines, infiltration of the tumor with lymphocytes, and objective tissue responses with this approach. Pembrolizumab was actually looked at in patients who had castrate-resistant disease post-enzalutamide, and as we see from this particular table from the responding patients, again, it was about a 10% response rate. Interestingly, 2 of these patients had really dramatic responses in liver, almost contrary to what you saw with the data from ipilimumab, but these patients had prior treatment with enzalutamide. So there are randomized trials that are going on right now combining checkpoint inhibition therapy with pembrolizumab, with atezolizumab. These are all checkpoint inhibition agents, hopefully seeing a synergistic effect between the two. This is some of our data with atezolizumab in castrate-resistant prostate cancer. This was our best responder. As we see here, as time goes on, we see that the tumor is infiltrated with CD8 cells. Interestingly, the patient did not express PDL-1 in its tumor, and from the other genetics of this particular patient, we found he was microsatellite stable, and he had a mutation in ATM, which is another component of the DNA repair pathway. These are our PSA declines. Really only 2 major PSA declines seen. It's about 10% of all of our patients treated with atezolizumab. But again, we're looking for selection factors for these patients. Now, question is more better? The combination of 2 checkpoint inhibitors, ipilimumab plus nivolumab, you probably have heard a lot about this in renal cell carcinoma. This is FDA approved for renal cell cancer. So since there really hasn't been terribly great data seen with single agent, what about combination therapy? So this was presented at ASCO GU this year. It's a combination of IPI plus Nivo. IPI is given at a high dose. This is actually fairly controversial. A lot of us are flipping this around and giving a higher dose of Nivo rather than a higher dose of IPI. And then patients go on nivolumab maintenance therapy after their initial treatment. These are castrate-resistant patients. 2 cohorts, 1 cohort who progressed after 1 second-generation hormone therapy, and the second cohort of patients who were post-docetaxel. Fairly well balanced in terms of their prior treatments. Nearly 60% of these patients did receive either abiraterone or enzalutamide or both. Again, both in cohort 1 and cohort 2. And the problem here is the number of patients receiving full dose. Only about a quarter in the second cohort and a third in the main cohort received all doses. And so you have to ask yourself the question whether it was the combination that was doing this. And the reason for this is toxicity. This can include skin toxicity as well as hepatic toxicity, and about 40% of patients progressed on this particular trial. Now, if we look at responses, they're not as as robust as we would like them to be. Cohort 1 is 25% for objective response rate, 6.3% complete responses. Cohort 2, it's 10%. If you look at PSA decline, 17.6% and 10% overall. So it's, again, not as great as we would like it to be. But if we start looking at some of these HRD status, which is the DNA repair status, and response, we start seeing a correlation. Both in Cohort 1 and in Cohort 2. Same thing with PSA response, seems to be somewhat better. DNA repair enzymes, same thing. Cohort 1, Cohort 2 seems to be better. But really where I think it's the most striking is in those patients who have high levels of tumor mutations within their tumor. This is actually somewhat surprising. I've never seen this high level of mutational burden reported in prostate cancer patients, but your response rates start approaching 50%. But again, look at your numbers, they're small in these patients who have high levels of tumor mutational burden. Radiographic progression-free survival, as one would expect in the earlier cohort, 5 months versus about 4 months in the docetaxel-treated patients. By PDL-1 status, the high PDL-1s tend to do a little bit better. These are combined from both groups. And again, when you start looking at tumor mutational burden, this seems to be the marker that stands out in selecting out patients. Overall survival is 19 months for Cohort 1 and 15.2 months for Cohort 2. So this is really hypothesis generating. We've really got to look at these DNA repair enzymes and mutational status to determine what to do next. Are there other studies that show something similar? The answer is yes. This is the Keynote 199 trial that was run by Johan de Bono. This took 5 different groups of patients. The way to look at this is to separate them are those patients who received enzalutamide versus those patients who did not, and then high PDL-1 status versus PDL-1 negative, and then no measurable disease as well. Median PSAs are fairly high in these patients, somewhat lower in those patients who had bone-only metastases. And if we start looking at the anti-tumor activity of Cohorts 1 and 2, we start, both these are the PDL-1 negatives and positives who did not receive enzalutamide. We see that about 11% had a 50% PSA decline. And if we look at the objective response rates, again, they're not terribly impressive. 5%, 3%, 5%, and 4%. So not particularly high. The PDL-1 positives did seem to do a little bit better overall with treatment. Now, whether that's a response to the immune system, or whether this is a prognostic factor is not really known. But the median survivals are about 9 months for the PDL-1 positive, 8 months for the negatives. But where we again start seeing this issue about DNA repair is in response, objective response, and PSA response. So if you've got BRCA1, BRCA2, or ATM, your response rate's 11%. The other DDR genes, it's 0%. If you're negative, it's 3%. So there does seem to be a difference between the two. Same thing with PSA, same thing with disease control rate. So again, this pattern about DNA repair. Well, can we get more bang for our buck? Can we then combine these agents, a checkpoint inhibition agent plus a PARP inhibitor, which affects those cells which have aberrant DNA repair, and can we see responses? This is a trial that Evan Yu presented at ASCO GU this year. Overall, patients had an median age of 69, a PSA of 129, about 12% of patients having disease in liver. About a quarter of patients were positive for PDL-1 in their tissue specimens, and no patients had HRD detected. So if we start looking at the HRD analysis of the 41 patients, there were different assays that were used. 37 patients had detectable DNA. There was 1 ATM mutation. 17 had soft tissue. There was 1 BRP1 frame shift. Again, these are involved in DNA repair. So if you start looking at PSA response rate from baseline, we see that looking at resist measurable disease is 50%. If we look at PSA decreases of 50%, it's 18%. Non-measurable disease, it's 54%. So again, we see some flicker of activity, but the question is, does this correlate with any of the other biological markers? Objective response rate, 7% overall for our patients. Disease control rate, 32%. and survival 13.5 months and then 4.7 months. Small phase 2 trial, so it's hard to really determine this. So this this combination is moving forward in a phase 3 study. Progression-free survival of 4.7 months, 13.5-month overall survival. There certainly needs to be further evaluation of this combination and further looks at the biological markers that are involved. So in summary, treatment with immunotherapy should be used early in the course of CRPC. Sipuleucel-T is approved for this indication. All patients should be checked for microsatellite instability because this can make a significant impact on our patients. And DNA repair mutations may predict response to patients treated with immunotherapy. We don't use the classic PSA declines. Survival may be the overall outcome with these patients. Thank you.